I'm working with elite athletes for the last 18 years in the Olympic Training Center, Spanish Olympic Training Center, and also in Football Club Barcelona. I want to introduce our experience with this new tool of fusion, MRI, ultrasound, and ask for its possible applications in sports medicine. In fact, this presentation has been done with the collaboration of some other colleagues, some radiologists, some experts in ultrasound, and we want to talk about this because first, a little background, after what is fusion in musculoskeletal, why fusion in sports medicine, how to use it. After I will show you some examples about fusion, a demo, and if you want, we can do a little discussion. In fact, as a background, many of us, many of you in the room have been working with something we can call manual freehand fusion of image as cognitive fusion. The ultrasound operator simply aims the US proof at the same area where the MRI demonstrates a lesion. It's simple, intuitive, quick, and requires no additional equipment beyond the MRI and the conventional proof. In fact, in this case, I want to show you, we can reproduce this image in ultrasound easily, and we do this kind of explorations every day in our office. First, some topics about my organization, about my club. We are not only attending 20 players of the team, we are attending more than 2,500 people in total from 14 different sports that plays more than 4,000 games a year in these different sports. We are focused on diagnosis, treatment, and prevention of injuries. Also, we take care of the sporting performance as doctors. We design educational programs for nutritional, for non-doping, etc. Also, we work for the athletes' health, fighting against doping, and take care of the events inside the club. We receive more than 2 million people every year in our facilities, and also take care of the health of the workers of the company. We do more than 8,000 medical attendance a year to our players. And in all the sports, we work with the common services, with the common protocols, with the common technology. And it has been very good to grow for the future. We have a decentralized organization with one main clinic in the training camps, in this. And we have also 3 decentralized clinics in some facilities. And we love to work with internal and external networking, as in this conference, to share our experiences and to learn more and more about the musculoskeletal medicine. We are focused on muscle and tendon for research, innovation, and new technologies. Is the part of the musculoskeletal systems that didn't have received enough focus on the past, because usually the companies put pressure to focus on the bone, the cartilage, and on the prostheses for the orthopedics, and muscle and tendons are not enough attended, but for us it's a big problem and a big challenge. The image diagnosis technology is very important for these reasons, and we must be attended to the latest therapeutic and performance methodologies. We are connected with the leader brands in the market, and also we have received the FIFA World Medical Center of Excellence. The key to manage this complex environment is the confidence. Confidence from the players and from their environments, especially from the staff on the board and the society. And how to achieve this confidence, it's important to have a top quality in our works, especially in the diagnosis. And also to have the knowledge that comes from the evidence and the experience. It's mandatory not to fail in diagnosis because the confidence is very easy to be lost if you fail. Our patients are living with us 24 hours a day, 7 days a week, and for us it's not well received, of course. And we must be inclusive, open-minded, and proactive to share the knowledge and work as a team. This is our last acquisition in our training facilities to MRI, Titan 3 Teslas. Why it's important, the image in sports medicine? Because the injuries, breaks from training, the cost of an injury, of a muscle injury in a regular population is not important, but in elite athletes, it takes every day of time loss, spent a lot of money that goes to the rubbish. Adequate treatment of injuries is essential for avoiding recurrence, and in recent years, the clinical use of musculoskeletal ultrasound has increased significantly, largely due to its diagnostic accuracy for many pathologies and at a significantly lower cost than other cross-sectional imaging modalities. It's a good choice for diagnosing conditions such as tendon tear, nerve entrapments, muscle strains, ligament strains, etc. Nonetheless, magnetic resonance imaging is still considered the gold standard for muscle injuries because its capability of detecting smaller injuries. The most important for us is to detect the small injuries. A big injury is not a problem for diagnosis. Anyone could diagnose without any of these devices. For me, the most challenging work is on Friday when one player has a little complaint in his muscles and I need to decide if he could play on the weekend. And sometimes it's necessary more accuracy, more sensitivity of the images. A combination, what is fusion? Finally, we enter in the topic. What is fusion? Fusion is a combination of MRI with ultrasound to improve the visualization of musculoskeletal injuries. We can reach simultaneous viewing side to side on real time. We can also see in the same plane, we must use the same plane and recognizable landmarks. For that, we use tracking sensors that works like the GPS. It's not well implemented in musculoskeletal medicine for the moment. You know that the fusion is used in liver and prostate cancer, especially for biopsies and also in gynecology for prenatal diagnosis. But it's very accurate. The error is less than 0.3 millimeters. And there are papers, there are reports about the accuracy of guided injections, especially in sacroiliac joints and in facet joints. For us, it shows it's a future technique for teaching purposes, especially for better understanding the ultrasound with the MRI. To perform the ultrasound, we use an Aplio 500 and with two antennas. One antenna is in the body of the equipment and the other one is in the probe. And we have fusioned images from the 3 Teslas the MRI and also with some MRIs provided by the patient self. First of all, we need to identify some landmark in the US image to look for the same image on MRI using the 3 axes on the space and the zoom. The MRI position must be taken in consideration if we take the MRI on prone or supine position. After matching the images, navigate within both images at the same time is possible, and to match better, you can continue refusing landmarks, as we can see after in the demo. The best anatomical landmarks are the bone shapes, the vessels, the tendons, etc. This is an example. We recommend to start with easy identifiable images, such as this 80-year-old football player with chronic anterior pain in the ankle. Both images show an anterior bone spur formed in the tibia causing the chronic pain as anterior impingement syndrome. It's easy to recognizable in both ultrasound and MRI landmarks, and you can choose this. The chosen landmarks are some of the anatomical ones that we have worked with in ultrasound, especially for anterior shoulder. We use the long head of biceps in the long axis, or the bicipital groove in the axial plane or short axis. In the hip, we use the anterior inferior iliac spine. In the anterior thigh, we use the central tendon of the rectus femoris. In the anterior knee, we use the patellar tendon and the inferior pole of the patella. And in the ankle, we use the anterior tibial tendon and the talar dome. And now, some examples. This is an example of a normal knee. You can see in the top, anterolateral view of the knee, where we use the iliotibial band insertion at the Gerdy's tubercle to fuse both images. Note the band insertion has a good quality image in both MRI and ultrasound, and it's easy to match the images between the both. And in the down, you can see the medial C side, and we use the medial collateral ligament to fuse both images. By zooming in the image, we are able to assess the MCL by ultrasound with good resolution, but give a limited field of view. You can observe in these images that ultrasound couldn't go deeper, but we can check, we can assess in this image easy going inside the joint, navigating in the MRI. This sagittal view of the medial patellofemoral ligament with the underlying here. This is the medial patellofemoral ligament, the underlying plica synovial, and also the synovial recess outside here. It's marked. In the posterior sagittal view of the knee, it's easy to see the cortex shape, in the cortex shape of the proximal plateau, tibial plateau, and the posterior cruciate ligament. It's easy to see there. This is a fusion that we use a lot for checking the proximal tendon of the rectus femoris and its insertion in the anterior inferior iliac spine. It's easy to see here the tendon, the direct tendon here and here, the iliopsoas and sartorius. In the next slide, in the next cut, when we go down, the iliopsoas, the tendon direct, and the indirect head of the insertion of the tendon that is difficult to see finally in the ultrasound, and it's totally difficult to see here. But we understand better with fusion how these tendons are related to the spine, and also to the cotylar shape of the cotylo. And the rectus femoris and his tendon, you can see that the images match very well in both. In this case, this is a 47-year-old athlete with history of chronic shoulder pain and instability who had an arthro MRI on his right shoulder. And it's a riskful approach to try to fuse an arthro MRI but it's feasible, as you can see. We use the long head of the biceps to fuse the images. You can see the humeral head and also the deltoid and the scapula. And in the bottom, it's the posterior approach of this humeral head with this infraspinatus and the disattachment of the labrum. It's easy viewing in MRI. We can understand that this image is the same. It's the same. And when we do this, after the identification of the injury, it's easier to check the stability of the lesion, because in the MRI we can move on real time if this injury is stable or not. One injury that is difficult to identify on ultrasound, after the fusion, we can check the stability. In this case, of an 18-year-old football player with a scar in his rectus femoris, in his rectus femoris intramuscular aponeurosis marked by the star. The fusion image showed an enlargement of the tendon. You can see also the sartorius and the other images. It's possible to assess the delayed onset muscle soreness by image, the DOMS. These images are from a 22-year-old synchro swimmer with a serious pain in her right anterior elbow after one heavy training session. MRI showed hyperintensity signal on the deep muscle fibers on the brachial fibers, characteristics of the DOMS injury, and the fusion image was obtained 24 hours after. And you know that this kind of injuries evolves very fastly, but also we can check that this increasing of the echogenicity in the same zone, and the arrows in this case show us the biceps tendons in the anterior face of the elbow. The better understanding of hamstrings injuries is challenging, especially in football medicine, because to know if the central tendon of the hamstrings is torn inside the muscle belly seems to be the most influential factor in the severity of the injury. This is a 18-year-old football player with an acute injury of the hamstrings conjoined tendon at the semitendinosus and along head of the biceps femoris. I show you both tendons, the central tendon and the semimembranosus tendon here. When we go down, the semitendinosus and the central tendon is little enlarged here. We can see the same image in the fusion, its relation with the gluteus maximus. And when we go down, this tendon is torn with a longitudinal injury, and when we can correlate with the ultrasound and the better understanding of the ultrasound that we perform weekly. And finally, this tendon has a longitudinal tear that, in our opinion, has very bad prognosis for the future of the player. This 20-year-old athlete with necrosis muscle from exercise is a rhabdomyolysis case induced after 100 kilometers training in running. We can fusion the image 1 week after the training session on his quadriceps, not the necrosis focused at the vastus medialis on his thigh, seen as hyperintensity in the MRI and a hyperechogenicity on the US scan. We can correlate, and for the follow-up of this severe injury, it's very useful to do the follow-up fusioning with the first MRI that we have obtained. Also, we can use fusion to assess injection, to guide injections, procedures. This is a case of a 19 years old female swimmer with a 3 weeks anterior pain in her right shoulder. The MRI showed a cyst under the coracoid process, which is hidden in the ultrasound. We cannot see in the ultrasound. But also we can see a labrum injury, neither visualized in ultrasound. and fusion image allowed an anatomical localization of the cyst for interventional guided procedures on the ultrasound. This is a 23-year-old female with pain in the sacroiliacs, and the correlation allows also the guided injection. And in the bottom, we can see another chronic low back pain with the right transversal sacral neo-articulation. And the fusion was done not with MRI in this case, but with CT scan. And the right transversal sacral neo-articulation could be seen easily in both procedures and to guide the injections. I want to show some videos to better understanding. Okay, this is a central tear. This is a rectus femoris central tear. You can see here in both images the correlation between the rectus femoris, the vastus lateralis and vastus intermedius, and the central tear. The rectus femoris central tendon injury in a football player. The axial view changed to sagittal in both images simultaneously. It's easy to assess the injury, to better anatomical understanding of the injury. In this moment, we change the plane from axial to sagittal, and we can understand better the injury and how in the ultrasound, the injury fibers don't disappear, but change its structure. The soft tissue deformation by pressure in real-time US. When we pressure on real-time US, of course, the MRI doesn't deform in the same way. We might take in account. The location where the vascular supplies, it's a very visible landmark, the vascular branches. The location where the vascular branches of they appear are excellent for landmarking. A medial collateral ligament and its relation with internal meniscus assessment for in this case, we can focus on a kyst to guide the injection after in the ultrasound, to guide the injection in the same kyst that we are seeing on the MRI. This is a case of a basketball player who has pain between the piriformis and the pisiformis bones in the ulnar carpal side, and after she needs we have a correlation of this axial view from the lateral side, and finally he needs the injection of hyaluronic acid in this small joint, and is easy assessed in the ultrasound correlated with the fusion. We can see how the fluid is entering in the ultrasound in this moment. Finally, some aspects of the fusion. It's about the learning curve. To match better, it's mandatory to choose a well-known plane. The planes during the synchronizing landmarks must be very perpendicular to the skin. The extremities fusion requires that joints don't move at all, because in other aspects of fusion, it's easier to have the patient still but in the joints and with the players, sometimes it's difficult. The time to match the images improve fast. When we start, we take 15 minutes to match an image, and now in 1-2 minutes, we have done the study and resynchronize the image as much as you need. It's an excellent tool in deepening ultrasound knowledge. MRI studies help to understand better the anatomy, but ultrasound is fundamental for sports medicine. The combination of the two image modalities improves the understanding of the normal and injured anatomy. And it's important. You know the advantage of ultrasound because it's very useful in the superficial layers and is best for the dynamic muscle assessment, but MRI is better for lower grade muscle injuries and deep muscle injuries, and also could check the associated injuries. Ultrasound is very useful to follow up muscle and tendon injuries. You can navigate easy, as we see after in the demo, within the MRI to look for the shadowed hidden structures. It's useful in guided injections, and it's very recommendable to acquisition of 3D sequences to change from plane to plane without losing resolution. High-quality images are mandatory with thinner slicing and the best resolution possible. Changing from region to region can disharmonize the exploration, especially in smaller joints. Elbow and ankle, in our hands at least, in the moment, it's difficult for the irregularity of the shape, but we're trying to do. And also in small joints, where in the fingers, for example, when we choose in the fingers, the arterial pulse of the sonographer makes the image pulse as well. And the exactitude of the GPS-like system makes disharmonize the image. Please take home these messages. MRI and ultrasound fusion technology is applicable yet in musculoskeletal sports injuries. Best anatomic landmarks for fusion are being described. As advantages, we are very happy with the educational proposals for the follow-up of some injuries, especially for muscle injuries. We can navigate inside the MRI in real time and guiding the procedures. The limitations is you need a high-quality MRI scans, especially 3D, and for the small joints, it's difficult. The research must continue, and I want to show the sentence of a business professors of the Barcelona University that say that when you have no knowledge of something, the best decisions come from intuition. When you know well, it will be more analytics from data and experience. However, when you are an expert in something, it is again intuitive. Although the later intuition is very different from the first because it comes with the experience. It's intuition with knowledge and experience. We work as a team, not an internal team, total world team. And I want to invite you to the next football medicine conference in Barcelona, the next May, in 2017. Thank you.